Okay guys, this is the second and it will be the final video for this calcium regulation lesson. One thing that, I'm doing these on iPhone here, and I've been told that, this is actually better. You can see me making gestures and all that stuff. And that's fine. I don't have to sit in front of a computer and just bore myself. And you. But I am going to be very curious about getting feedback on these videos. I am, first of all, worried that perhaps some of the text is too small. And if that's the case, please let me know. And I'm also worried that you may not be able to hear me because I'm using the iPhone's microphone. And I have tried external mics. I have earbuds and stuff, but they don't seem to work with the video. So hopefully hearing me isn't a major issue. So we're going to talk about vitamin D and then calcitonin to wrap this sucker up, all right? So first of all, vitamin D, the quote, secretory unquote gland that we're of record, we're going to say is the kidney, because this is the final step in the process. This is where active vitamin D is made. However, you should bear in mind that it is a complex process, that 4 organs are actually involved, and that diseases of any of the 4 could actually cause a problem. We'll get to that in a moment. But the final steps in the kidney, that's where the active form is made. And it increases the intestinal absorption of calcium, okay? And so that also is what you should bear in mind. That is the primary organ of action. Now I'm going to show you the kidney as well, and bone, of course, is indirect, but nevertheless, you should bear that in mind, and you should also bear in mind that it is largely under the regulation of PTH, because that is involved in making the active form, it stimulates it. So here is the process by which vitamin D is made. It can come from either one of 2 places. First of all, you need a diet. You can have a dietary source. It's ingested and absorbed in the intestines, or actually UV light can help convert a form of cholesterol to vitamin D as well, and you can make it that way. So if you have a patient, their skin's always covered up, this could be a problem. Of course, intestinal problems could lead to problems absorbing vitamin D, so you should bear that in mind. The liver is where the vitamin D comes in, and this is where the intermediate 25-hydroxy vitamin D is made. And then the kidneys are the final step, where you have vitamin D either made into the active form, 125-hydroxy vitamin D, or sort of an inactive form, 24-25-hydroxy. This is probably the form that's excreted in the urine. My guess is that you just have this unregulated amount of vitamin D coming in, and this is the kidney's way of only making as much of the active form as you need. And if you don't need that much of the active form, then this is the form that you excrete it. It turns it into an inactive 24-25 and then excretes it in the urine. So it probably can go down either branch at that point, and it depends on how much vitamin D you need to regulate your calcium and phosphate. Okay? So note that even though the active form is generated in the kidney, diseases of any of these 4 organs can result in vitamin D associated problems. So if you get a stem and it's a patient, and the patient has some disease that affects one of these 4 organs, particularly in this block, one of the things you should consider is that it may be a problem with vitamin D. All right? So do bear that in mind, and that is the primary reason for emphasizing it and for producing this slide, to show you what may largely look like inconsequential steps when the important one is in the kidney. Disease of any of these can cause a problem. The primary action of vitamin D is on the intestines. So let's talk about calcium absorption in the intestines. This is a typical enterocyte. Calcium is absorbed and passively passes through a channel in the apical membrane, and that calcium at least can go through one of two paths. First of all, it can bind to calbindin, which is a calcium binding protein. So the calcium comes in, and by binding it immediately to a binding protein, you keep the free calcium concentration down in the cell. That does two things. It maintains this gradient, so that calcium will continue to come in. It keeps calcium low, free calcium low. And it also keeps free calcium from building up and killing the cell, which will happen if the calcium gets too high. So calcium binding to calbindin keeps you absorbing calcium because it keeps the free calcium low, and that calcium calbindin diffuses and the calcium unbinds and is extruded through the basolateral membrane through either this calcium ATPase or through the sodium-calcium exchanger there. And so calcium is transported out, so it goes from the intestinal lumen into the enterocyte and then out through these active transporters in the basolateral membrane. So these are really what drives the transport. This is, so it does require energy to absorb calcium and keep the calcium inside here low to keep calcium moving, okay? The other pathway, calcium may be entrapped in vesicles through endocytosis, and then those vesicles may release calcium through exocytosis through the basolateral membrane, okay? So what does this have to do with vitamin D? Vitamin D increases the absorption of calcium from the intestine by increasing calbindin, okay, in the enterocyte. So it causes more calcium bound to calbindin, which means your total calcium in the enterocyte increases, and it also increases the absorption of phosphate. Then if you get more total calcium, that means you can transport more total calcium through these transporters, and the absorption increases from apical to basolateral and out into the serum, all right? And don't forget, PTH increases the active form of vitamin D, and it really regulates that. So indirectly, PTH actually regulates this as well, okay? So here's a quick summary of vitamin D's actions. This is the one to remember. It is the primary target, the intestines, increasing calcium and phosphate absorption. It does act on the kidneys to cause calcium and phosphate reabsorption there, so you're maintaining calcium levels and phosphate levels there. And it does act indirectly on bone, as you know. It allows parathyroids to appropriately release PTH in response to the serum calcium level, and without it, you'll get more PTH released than you should, and it'll increase reabsorption, so this is very indirect, okay? And then all of these increase the plasma calcium. So calcitonin is released from the thyroid gland, and it is released in response to increasing plasma calcium. So it's the opposite of PTH. One thing to note, although the regulation is real and it's there, you can actually live completely without calcitonin. I mean, you can drop the levels in the serum to zero and not allow the body to secrete it, and you'll still live, okay? You won't live without PTH. So that should tell you something. The effects are real, but it isn't like critically important, and they aren't massive effects, okay? And it's thought that its primary function is really to preserve bone mass in the face of disturbances that would overly demineralize bone. As much as anything else, that seems to be its purpose. But the thing to remember, its secretion goes up when plasma calcium goes up. Its actions are on bone and kidney. This is the primary one. It increases bone formation and decreases calcium and phosphate release from bone, okay, and therefore decreases plasma calcium. Okay, so the more CTH you have, the more the tendency to decrease plasma calcium back toward normal. The effects on kidney are there. They increase phosphate and calcium excretion, so you lose more calcium and phosphate in the urine, but they're minor. You know, PTH is your big guy for the kidneys, okay? So they're real, you need to remember them, but don't think that they're overwhelming. It's overwhelmingly important either. And again, I just said that not required to maintain life. That should tell you something about it. It's not that the effects aren't there. It should just tell you something about how important they are relative to regulation by PTH. And then this graph, one that you want to remember, as plasma calcium goes down, PTH release goes up, okay? Meaning PTH wants to bring your calcium back up, and calcitonin goes down. So as plasma calcium goes up, PTH goes down, calcitonin goes up, that'll increase bone formation, or at least decrease the breakdown of bone, and tend to preserve calcium in bone mass, and tend to make this plasma calcium come back down toward normal, okay? So these are inverse. Decreasing calcium decreases calcitonin and increases PTH. Increasing calcium does the opposite, decreases PTH, increases calcitonin. And through the action of these two, this is primarily how you regulate calcium in the serum, along with some help from vitamin D, which is very closely related to the PTH, okay? So acting together, these serve to maintain calcium regulation, blah, 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 right? So they try to keep that plasma calcium at a relatively constant level, just like your cardiovascular system tried to keep blood pressure at a relatively constant level. Okay? So that's all I got. Thank you for your attention. Good luck. Talk to you soon.